Welcome to the Sunday special on TopMedTalk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. TopMedTalk.
All right, I'm Desiree, Chappell, lead U.S. anchor for TopMedTalk. Welcome back. We are with the trainees with an interest in perioperative medicine, TRIPOM. Any questions? We're live in London for the closing of EBPOM 2018, actually, and I'm joined here by my co-host, Monty Mythen, editor-in-chief of TopMedTalk. Returning to our panel, we have TRIPOM's co-director, Dr. John Whittle of Duke University, and Katie Samuel, co-chair of TRIPOM. And joining us now, we have Ross Kerridge. He's from the University of Newcastle in Australia, and many of you may know him as the modern father of perioperative medicine. Right, Ross?
Well, maybe. Thank you.
And we have also Lee Fleisher. He is the professor and chair of anesthesiology and critical care at the University of Pennsylvania Perelman School of Medicine. And he's also the chair of the Brain Health Initiative with the American Society for Enhanced Recovery. Lee, thanks for joining us. Hey, can you tell us, start off by telling us a little bit about what the ASA's Brain Health Initiative, what it is, and who's involved?
Sure. So it's not the ASA, and as you said, the second time it's the ASA. And it was an attempt a couple of years ago for us in the academic community to push the ASA into recognizing that although the Institute of Medicine lauds us for doing a lot of safety work, we hadn't done any for about 20 years, really, as a focused national initiative. So at the behest of Dan Cole, who was a neuroanesthesiologist and then president-elect, we embarked on a 2-year journey to really engage multiple stakeholders around making both the public and the providers aware of the risks of postoperative delirium and what we now call delayed cognitive recovery, or POCD, postoperative cognitive dysfunction. So over the next probably 6 to 12 months, we'll be providing resources and really working with partners in surgery, nursing, public health, public policy in the U.S., as well as our federal government, in pushing on an agenda to say hospitals should have a protocol for how to take care of geriatric or older patients as they present for surgery. So,
great. Well, I think that actually takes us to our first question. Monty, do you want to?
So this is a question submitted earlier online. We're all being told that we should screen for frailty. What do you actually do in your current practice? Ross, has this hit the radar in your neck of the woods?
It's very much hit the radar, and it's something that we're tackling or we're putting a lot of attention to, particularly one of my younger colleagues, well, all my colleagues are younger now, Pragya Rajacharya, who's a very talented younger colleague of mine. But I don't think anyone's got the answer yet. I mean, there are lots of tools that we can use, different systems for screening for frailty. Most of them have been developed from the geriatrics rather than in the surgical context, and I think that raises a whole lot of questions. The Edmonton scale is very good. It's a simple scale, but in fact, once you get up to the high end, you're thinking these patients aren't going to be having surgery unless it's emergency anyway, in which case the screening thing doesn't particularly matter, other than directing your attention to what you'll do to them post-operatively.
It feels like we need a sort of ASA score for frailty, something that we all learn.
Yep.
You know, are we any closer to that? That's part of the challenge, isn't it?
I think that's a long way off yet. Or not a long way off, but I think 5 to 10 years.
John Whittle. Sorry, Lee. Go for it.
Yeah. No, I mean, there is the Freed scale, which came out of Hopkins, and I worked with Linda. The question is that these are complex and not everyone gets all the tests. It would be great to get an albumin on everyone. Yep. As one of the key scores that would go into these. It would be great to get some of the activities that they have. But I think until we've got them easily incorporated into our electronic medical records, that's the future.
We're getting a microphone over here. We've got a question coming in from the floor. The question was frailty, and are you including physical frailty and mental frailty and cognitive dysfunction? What on all those spectrums of what may or may not constitute frail? Lee, where do you stand on that?
I think of physical frailty, but I think that feeds into cognitive frailty. I mean, it would be great if we could both get an albumin, get an idea of what activities they do in daily living, and get them to draw a clock face. Interestingly, at the University of Pennsylvania, we don't have a pre-op clinic. When our system almost went bankrupt, they actually took out the pre-op clinic because the surgeons thought they could do it really well. We almost delay almost no one, but they don't look at their outcomes. And I would say that's a problem.
Would it be reasonable to say if you can draw a clock face and take a photograph and send it in, you don't have to come to pre-op clinic?
I think we can do a lot online. We got Ross's. I mean,
we'll get Ross back on that in a second. We have a question from the floor. Hello. So, sorry, I should have said the first round. Could you please introduce yourself, just in case your mum's listening?
Hi. So my name's David Harvey. I'm a trainee down in Southampton at the moment. So I've been looking into my research here into a bit of frailty, so it's a bit of interest in my own. But I'm just interested on people's opinion at the moment, certainly in the UK, as part of mandated in the GP contract last year, that all patients over 65 should have an electronic frailty index score done. It's kind of based on the Canadian Study of Health Agency and the sort of focus on those points. And that's used for the GPs to then screen. But I'm intrigued from a perioperative side. Patients are going to be coming through the door, emergency surgery, with this score. And what are we going to do with that?
Yeah.
Okay, John Whittle.
What are we going to do with that score?
Or general comments on this subject area. What is happening in your practice at the moment, and then perhaps loop back on some of those other issues. And not much is an okay answer.
Actually, quite a lot. I think this is a really, really hot topic. And over the last couple of years, become, burning bush. You've got sort of Lee Fleisher here and Brain Health Initiative and so on. I think I'll start with what we are interested in at Duke at the moment. We're certainly starting to set up studies looking at prehabilitation from the point of view of maybe a triad of frailty with physical fitness, sarcopenia, so nutritional status, and all the other frailty indicators we're talking about, such as cognitive function, so on, all encompassed in this sort of overlapping diagram. So one frail patient may have deficits in various different areas, and I think we don't know where to go with that. So that's an area of research. Certainly when I was a perioperative fellow at UCLH, we integrated or started to integrate a whole variety of frailty scores into our assessment of the higher risk patient. It'd be interesting to hear, Katie, who's currently doing that job, if we are still doing that and where you've gone with it.
Katie?
So the short answer is no, we're not. I think so again, similar to as you say, frailty is a real interest amongst a lot of perioperatives at the moment. And what I find interesting is the fact that the number of publications on frailty is going up exponentially over the last 5 years. But in terms of people actually implementing change based on these papers, there is very little change. And so I think the question of what do you do knowing someone is frail is the key question. And the other important thing to think about, I think, is how frailty changes through the perioperative period. So somebody who might start off as not frail, do they become frail after a major surgery, and what can we do about it?
Lee?
So it's an interesting thing at the Brain Health. We had a lot of policy people there, and our Medicare also pays for screening just in the GP. And the question became, given how quickly we frequently send people, and I heard the concept of what's your tolerance for waiting from Saul Aronson. The question, if we are going into population health, just like we do smoking cessation, which even if it's a short term, our goal is to make it long term, could we actually use the perioperative moment as an idea to get people into rehab, so to speak, or conditioning again, not just for surgery, because we don't have the data to say it makes a major difference, as we heard, but we know there's a lot of data to say it makes a difference long term if they're exercising, eating healthy, doing all those other things. So it's an interesting population health perspective.
Ross?
I think the real advantage of thinking about frailty is that it opens the doors for what you might do and what you can do preoperatively. I think the big thing is to have the conversation, to raise the topic, to having said, okay, we've got these indicators that there may be problems. It's the big breath. Sometimes in our situation, it's the registrar may have seen the patient and then they call in the old doctor. And and we say we need to have a talk. And having the talk about, let's just think about, do you really want to go ahead with this surgery? And even if you do, let's think about where it may go. And then, the conventional thing is to then go into advanced care directives and all this. Although we've had quite a lot of discussion about this, and often it's, rather than having the advanced care directive with the a la carte, I'll take a ventilator but not a tracheostomy, and I'd like cracked pepper on my ventilator and all this, which I find a little bit dysfunctional. But we say we want you to go home and have the conversation with your family and talk about exactly what your goals are, and so that we know if things don't turn out the way we would like, 48 hours down the track in intensive care, that we know who we need to talk to, and we're confident that they know what you would want in this situation.
But also on Lee's point, I think those issues are very, very important for the longer term planning, but the population health benefits. Yep. I thought in Australia, from the sort of general prehabilitation things, you were ahead of the game from that position. For exercise in particular, I think you could prescribe exercise and community gymnasia no? Have I got the wrong? I'm just hearing that from some of my Aussie friends who...
Yeah, I think that's what we should be doing.
Okay.
And if you're going to prescribe exercise, that's the way to do it. I mean, the hospital-based programs that you've been doing here up in Middlesbrough and Southampton and other places, I think that's the ideal. I don't think there are many places in Australia doing that.
It would be interesting. We were starting to talk to the YMCA, which has gyms and exercise places. Why couldn't we actually give them a free 2 to 4 week membership at some fancy gym in London and get them exercising before surgery, and then they have to pay if they continue, but they're going to be in much better shape.
Yep.
And it's actually a really innovative concept, but we may try it at home.
And we've had some great success with that sort of thing. So.
Well, my question was very similar to that. Just, what are you going to do with the scores, and how do you treat these patients differently? And I think as trainees and being in this situation going forward, how are you going to start having that discussion?
I think one of the key flaws in part of our shared decision-making process is that most of the risk assessment and prediction tools we use don't have frailty incorporated into them. And that's something which quite often you'll see a patient, you'll do their PPOSM or their SORT score, and it will be lower than you're expecting, and that doesn't put it into the context of somebody who's frail. So I think, first of all, making sure trainees are aware of frailty, which I think is becoming more common in people's minds now that it's becoming a more popular topic, is the first step, and to recognise that actually it goes beyond just risk assessment tools. It goes to looking at a patient holistically and having the sort of conversations, as Ross was saying, where you really outline what morbidity is. And as we know reasonably well, what matters to patients is disability-free survival and quality of life, and making sure that they understand that just surviving is not the most important thing. It's having that quality.
All right, we have a question from the floor. What is your name and where are you from?
Hi, my name's Annie McCarthy. I'm an anaesthetic trainee in the northwest of the UK, Manchester. Thank you very much for your comments. I just wondered, we've heard a lot about nutrition and exercise in terms of prehabilitation in this conference. Specifically for the frail patient, if you had all of the resources available to you, how would you design a specific prehabilitation program for these patients?
That is a great question. Lee, let's start with you. We'll just work our way down the table.
The thing I'd worry about is trying to activate them beyond what they would activate themselves. I'm very intrigued by something called the patient activation measure, which sort of gets to, if my kids tell me I have to be at the gym 7 days a week, I'm not going to start. But if I can get to 3 days a week, so prescribing that, and I think you've done it much better here in the UK than we have in getting people activated, but that's sort of a subset. So I'd start them on at least walking 30, 45 minutes a day, 4 or 5 times a week, rather than staying still. In feeding them, one of the most interesting things is an experiment at Geisinger, which is a health system in northern Pennsylvania, which is our coal area, very blue-collar poorer neighborhood, but they're also the insurer. And I heard a little bit of this from Sir Bruce Keogh, the social services. I mean, if we could actually, people have talked about, there's something called Blue Apron in the U.S., I don't know if it's here yet, where they actually send you food that you can cook. So rather than have them go to their actual store, send them vegetables and send them healthy diets for the week or two before surgery. They're doing this for diabetics. It's costing them $1 million a year. They're saving about $5 million in the cost of care. Their hemoglobin's A1Cs have gone to normal quite quickly. But you actually have to also teach them how to prepare it. So they do classes that are sort of group thing. So I think I get them walking, and I actually think about feeding those who do not have good nutrition.
Lee, and one step further, we talked with Miles Berger today and about not just nutrition and exercise, but brain exercises as well.
You know, it's interesting. Luminosity, nobody knows if any of those things work. I would say that what we know for the brain long term is exercise, drinking being in moderation, so they can't go pub crawling every night, and nutrition will do as much, I think, as making them do crossword puzzles or luminosity or any of those other things.
All right, Ross, perfect world. What would it look like for you?
I think for us, I think for the planned surgical patient, exercise is the big thing, or exercise and getting their diabetes under control, stopping smoking. But of the prehabilitation thing, the nutrition thing, maybe we have less people malnourished in the planned surgery situation, other than being overnourished.
but that's
still very undernourished.
So I don't think it's malnourished. I think it's overnourished and not properly nourished, and that hemoglobin A1C. I mean, so many are diabetics.
But certainly exercise, and our general formula is about half an hour twice a day.
All right. Well, we have a couple more questions from the floor. All right.
Sam, I'm one of the anaesthetic trainees from the Midlands. I'm interested in prehabilitation particularly, and I think obviously diet and exercise play a huge role in some of these patients. What you're suggesting requires quite a lot of intrinsic motivation, and quite a lot of our elderly, frail patients are suffering with mental health conditions, so depression, which actually means they don't have that motivation. Do you think there's a role for psychological therapy for them as well?
John, let's get your perspective from Duke.
Probably. So I'm very interested in all the talk we've been about the teachable moment here, and what you carry on with after your surgery and so on. I have a few comments on that in terms of effective exercise interventions in the preoperative period, where I would question, both from observation in trials that we are enrolling in at Duke at the moment, and from reading, the efficacy of a walking intervention in the short period between decision to operate and surgery, i.e., from my reading of the literature, if you believe in aerobic exercise capacity as one of the great predictors of perioperative outcome, METs aside, then actually the ability to improve in a clinically meaningful way peak VO2, AT, may be limited by those sorts of interventions. Going back to the ideal world question, in my opinion, the ideal world would be a continuation of the practice of regular exercise. In terms of motivation to exercise on your own time pre-surgery, again, what we have found is that we've had a relatively low uptake in asking our elderly patients to increase their activity levels. And certainly one of the studies that Miles Berger is doing is just that. He's asking these patients, aside from some supervised exercise, to improve their general activity levels. And we've been struggling to, number one, recruit to that, and when we do recruit to that, to see improvement. So it will depend on your patient population and location as well.
I think your intrinsic motivation comment is key. We do a lot of behavioral economics with incentives at the University of Pennsylvania. Kevin Volp's written about 10 New England Journal articles. Nothing sticks if you do extrinsic motivation, so it's got to be intrinsic. With the behavioral health, we've actually embedded behavioral health workers in our primary care clinics. Huge difference, because the incidence of depression in these elderlies is very large. So I think that would be one of the key approaches that we haven't taken. I don't know if you have at Duke or at UCL.
No, not yet. And I think this is the key thing, isn't it? You do need intrinsic motivation. You need structure to promote that and a way of communicating that. And we haven't done it.
I think we have time for one more question there in the back.
Hi there, I'm Louise. I'm from the anaesthetic training in the Southwest region. It was really probably just to touch on some of the themes that have been covered already. But I know the guys in St Tommy's group set up the POPS program, which was sort of a dedicated service looking at improving perioperative outcomes in the elderly. And I just wondered whether the panel had any comments about this program and whether you felt that was sort of a model that does incorporate a lot of the sort of issues around frailty, whether we should be looking at something like that, in the wider sense across the country.
Katie, is that something that you're familiar with, the POPS
yes,
program?
Reasonably. I think POPS is really a flagship centre within the UK. There's not really anywhere else that is doing it. And in terms of what they do, they're basically thorough medical care for these patients. And they do comprehensive frailty assessments at their pre-op clinics so that they're better informed as to their high-risk patients. I think that in reality it's something that all trusts that do high-risk surgery in elderly patients should have. In terms of the practicality of implementing, that's a very different thing. But I think it really highlights the importance of perioperative medicine not just being anaesthetics intensive care, but actually being truly multidisciplinary. And I think it's very easy to give full credit to the geriatricians on the POPS team, but actually they're very well supported by physiotherapists, by OT, and it's all those complementary specialties that I think are key in improving their outcomes. So to answer your question, yes, POPS is an excellent service, and yes, ideally it should be something that's run throughout the UK, but I think we're still a little way ahead from that. We're still struggling with some of the basic elements of ERAS and perioperative care, but for the future, certainly, I think it's something that we'll see.
So we're coming close to a wrap here. Time is against us. So thank you all for joining in with the inaugural TopMedTalk TRIPOM Any Questions? But just before I do the final wrap, just a quick comment from the panel. Perioperative medicine, the future of perioperative medicine. It's a room full of enthusiastic young doctors who I think this is going to be part of their career going forward. Lee, is it the future of our speciality, or are we there specialty, or are we there already, or have been there for ages?
It's absolutely the future of the specialty as long as we embrace the other specialties as part of what we do going forward. Atul Gawande, when he took his new job at Amazon, Berkshire Hathaway, and JP Morgan, said surgery is the biggest issue and probably our biggest expense in the world, both too much surgery and not doing the right procedure at the right time, and I think that's perioperative medicine.
And or most of the world doesn't get access to surgery at all.
Yeah.
Ross?
Yep. I think one of the really exciting things for me has been starting in Britain. While I was here as a registrar, but then in terms of setting up the system in Australia, then seeing what happened in Europe and in the UK and in the US and in Canada, that with widely different systems, everyone's coming to the same solution, that perioperative medicine is a multi-specialty, multidisciplinary team game, that depending on the context and the hospital and the service, one specialty may be more dominant than others in terms of organising it and all that, but essentially it's still coming back to the same model.
And just to be clear on that, when we say perioperative medicine, we don't mean a thing delivered and done just by physicians either, do we? We mean across the board. Katie?
No.
So I think for anaesthetic training, which is all I can really comment on specifically, I think perioperative medicine has always been part of our practice, but certainly within training there's two groups, those that feel that it's not part of an anaesthetist job, and others that feel that of course it's part of our job. And I think what we might see in training in the future is perioperative medicine becoming a distinct subspecialty similar to ITM, similar to pain. But I think it's inherently part of our training, and it will continue to be.
John?
Absolutely. So I think At the centre of all this, we have a patient, a surgical patient, who we are trying to do the best for. We've had to reframe the surgical journey to within the larger context of their life, and this is going to be a multidisciplinary team game. That's why TRIPOM is multidisciplinary.
Just ask Sam Bampo to make the last comment on this, who's one of the TRIPOM leaders, one of the founders of TRIPOM as well.
Yeah, thanks, Monty. So first of all, thank you to TopMedTalk for hosting us this evening at EBPOM. I think it's really inspiring stuff. We've got a room full of the perioperative physicians of the future, and I think it's really interesting to explore what role everybody in this room can have in improving outcomes for patients in the future. A shameless plug, TRIPOM is really interested in frailty. Our last two tutorials explored perioperative cognitive dysfunction and also frailty. So if you want to access those, have a look at our website. And there are plenty of educational materials available for trainees. This is a key topic for all perioperative physicians of the future. And I'm really excited to see where we go with this.
Well, thank you to TRIPOM for giving this opportunity. Thank you to all of you for coming, and particularly to say thank you very much to our guests. So thank you very much indeed for listening.
TopMedTalk. Thanks for downloading and listening to TopMedTalk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMedTalk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.